which is crazy. But I'm gonna do my best. Apologies if I didn't get to all the slides. Um, I think one of the most important aspects of dry eye is to really to define it, and this is the best definition I've seen ever. We talked a lot in the talk about MIBO, about dry eye, what it means, and what we're trying to achieve is really homeostasis of the ocular surface. Okay, so this looks messy, but it really is a great tool. So this again is from the TFOS DEWS 2. What you have is basically what do you do? How do you know this is a dry eye? How do you know it's not something else? If you see a patient that's asymptomatic, but they have signs of dry eye, it's NK, right? We talked about that, right? But if the patient is symptomatic, they've got signs, or even if they don't have signs yet, then it's probably dry eye. And when we look at dry eye, we can see that's predominantly evaporative. It could also be aqueous deficient or it can be mixed. So there's a lot going on here, but keep in mind that most of your patients are going to be evaporative. I think it's somewhere to 70 to 80%. Okay, so what we're trying to do, again, another messy slide, but what we're trying to do is reduce inflammation. Okay, now we talked just now about IPL and how beneficial IPL can be in reducing inflammation, but we talked also about lifitegrast earlier. So there, what we're really trying to do is reduce inflammation because dry eye, so tear film instability causes inflammation, and inflammation causes more tear film instability. So it's a vicious cycle that needs to be interrupted. And all the treatments that exist for dry eye are trying somehow to interrupt this cycle. Okay, so why is it important? Basically, dry eye is so common, millions of people. It is such a financial burden, about 3.8 billion in the US healthcare costs and 55 billion lost in productivity annually from dry eye. So this is huge. 85% of dry eye cases linked to MGD as evaporative component. And modern triggers would be screens, pollution, climate change. Basically, we're seeing a ton of screen use now. So I think one of the most important aspects of dry eye is prevention today. So this is what the healthy eyelid should look like. Okay, so we all learned about this. This is great, but this is not what we see. Okay, so basically the eyelids have what's called the meibomian glands. As you guys know, meibomian glands are producing oil, which is a key component in the tear film. Oil prevents the evaporation of the tears, and so when you have any dysfunction of the meibomian glands and the oil is not being secreted properly, then you will lose that oil tear film, or that oil part of the tear film, and then you get excessive evaporation. And excessive evaporation causes blurry vision, it causes burning eyes, it causes discomfort. So this is something that we can address. So this is what a normal meibomian glands look like, and then we can see mild dropout, we can see moderate and severe. Anyone here do myopography? Great. So myopography is such a key part. I think it's one of my favorite devices, and I think anyone that I suspect, which is basically everyone, will do myopography in the office. And as soon as you see, again, it's progressive, just like a lot of other conditions that we talked about. And when you have something that's progressive, we know it's going to get worse if it's not treated, especially if they continue doing things that lead to that. So screen time. Why screen time? Anyone know why screen time leads to problems? No blinking. So what happens? It's the blinking that helps release that oil, right? So if you're not blinking, oil will just sit there, right? And it will become inflamed and solid. And then if you add ocular rosacea to that, you add all other factors, it just makes it worse. So the cornea depends entirely on the eyelid for protection, right? Blinking, we talked about the cornea being the shield of the eye earlier, but it's really the eyelids that protect it, right? So if there's a problem with the eyelids, then we could lose protection essentially of the eye. So let's talk about acute, because that's something that is less common. I would say chronic, most of the dry eye we're seeing is chronic. So let's talk about acute real quick. This would be a patient who has symptoms. So sudden discomfort, redness, epiphora. You see a high MMP9, rapid tear film breakup time, maybe some SPK, corneal staining. So what can you do in these patients? Maybe artificial tears. We talked about punctal occlusion, Lacrophil, and in-office, those are in-office procedures, short-term steroids, basically. But what you're doing in these cases is also doing a meibography, right? Because if you can look at the meibomian glands and see that they're normal, but that this patient is having these symptoms, then likely it's not meibomian gland dysfunction. It is not something chronic, right? You also want to look at their tear film meniscus and make sure that it's normal. So other things that, some artificial tears that can be used. So there's different ingredients that we see in organic ions, electrolytes in these artificial tears. They basically increase tear volume, minimize desiccation, lubricate the ocular surface. They have different ingredients, as you can see here. Some of them have glycerin, some of them have multiple ingredients in them, as well as high oncotic pressure. You can use gels as well. So gels are good because they help lubricate overnight. They also stay a little bit longer on the eye. The only thing is that they do cause blur, and sometimes the eyes feel sticky. So that's something you want to tell your patients. So make sure whenever you're giving preservative free that they're, whenever you're giving artificial tears, that they're preservative free. And I think this is really important. Essentially, you're trying to lubricate and hydrate the ocular surface. So don't give anything with preservative in these cases. So we know that steroids work a little bit better than NSAIDs. They decrease HLA-DR, positive cells and symptoms. And so we know that people with dry eye do have flares. And so this is something that can be used short term for these patients. So let's talk about this acute study. So a 28-year-old female presents 2 months after LASIK. She's got good vision, you know, the refraction is okay. And then I think what's key here is the meibomian glands look perfect, right? But you're seeing a break of time that's a little bit low, a little bit reduced, right? And so in this case, what I would do is artificial tears, steroids, punctal occlusion, make sure the patient's taking breaks when they're working, and nutraceuticals are great in this case, like omega-3s to help reduce inflammation. And then you do want to follow up the patient. If you're seeing that this is ongoing, it's probably not acute, okay? But if it's one and done, then you know this isn't acute, just had LASIK, you know, there's a trigger there, and this is just gone. But again, most of our cases are chronic and complex, so that's what we're going to get into. So a lot of the time, the chronic is going to be because of eyelid, lid margin disease. And as we mentioned earlier, 85% of our cases are evaporative, which is linked to the eyelid. So meibomian gland expression is something I highly recommend. I see a lot of your videos, Tammy. But is everyone doing this on their patients? So even if you don't have a meibographer, you can, does anyone do meibomian gland expression at the slit lamp? So there's two ways you can do this. There's the meibomian gland evaluator, and then there's the manual meibomian gland expression. So it's a little bit different. MGE, the one you see on your left, basically what you're trying to do with this device is see that the meibomian glands are open and that they're releasing fluid or oil, meibum. In the second, you're trying to see the consistency. So it's a little bit different, right? This is more quantitative because you're trying to see how many glands are open, and it should be about 42. And when you're looking at the right side, you're really trying to, it's more qualitative. You're trying to see the consistency. So again, when you see something like the toothpaste sign, you know that there's a problem. If you see that with the MGE, that the glands are not open, that they're not patent, then you know that there's an issue with the actual secretion of the glands. So I talked about meibomian gland imaging. So this is actually a really old test that used to be done with just a transilluminator, as you can see up here. But now we have all these amazing devices, infrared light, that can really show us the meibomian gland health. And this has been a real game changer in educating my patients about dry eye, evaporative dry eye, and lid margin disease. Speaking of lid margin disease, we're talking about the biofilm. This is the bacteria that live on the surface of the eyelid. And then, of course, our friend Demodex, which we know is so common today. Almost everyone I see has this. All you have to do is ask your patients to look down. And that really changes a lot, because when you have them look straight ahead, you really can miss those collarettes. When you have them look down, you can really see them. And so even though sometimes it's not the easiest thing to diagnose, it's almost impossible unless they're looking down. And Demodex, as I mentioned, is so common and very treatable today, something that we didn't really have a good treatment for up until now, and now we do. And so it really makes a difference to diagnose and treat these patients.
Question real quick
Yes.
about are there any tips that you have for manual expression without the patient wanting to kick you under the chair?
Yeah, so it shouldn't be painful. It shouldn't be painful. It's just a little bit of pressure. If they're really blocked, sometimes it doesn't come out. I would say don't force it. Maybe do a treatment instead before you do expression like that. You're really just trying to see, is this toothpaste or is liquid? And you shouldn't have to really squeeze the eyelids too much. So.
And then would you recommend MMP9 testing over osmolarity?
Not necessarily. I mean, I think that any way that you can detect inflammation is great. I think a lot of the time, if you don't do these tests, you can still know that there's inflammation by using your other tests. So I think the more you can do, the better. But I don't think one is necessarily superior than the other. So back to Demodex, these actually damage the eyelids in three different ways. Mechanical, by actually just micro abrasions on the surface of the eyes with their little claws, which is really gross. They also carry bacteria in their gut. So there could be bacterial infestation as well. And chemical, they have all these digestive enzymes and regurgitation on the surface. Sorry if anyone's eating. On the eyelashes, which can lead to just eyelash distension, eyelash loss, and inflammation. My favorite dye of all time is Lissamine Green because it really highlights conjunctival staining. Corneal staining is a little bit more obvious, and sometimes we miss this lid wiper epitheliopathy, which can indicate a lot of friction between both conjunctivae. So basically the bulbar and palpebral conjunctivae. So you really can see that the eyelid in this case is rubbing on that ocular surface because of all the cells that we're missing. And a lot of the time, I think conjunctival staining can be quite painful. And so I really do use Lissamine Green. The trick for Lissamine Green is you put it in the eye, you wait 2 to 3 minutes, and then you look. Same thing with fluorescein, actually, but it's also a great tool for looking at corneal staining. Oop. Okay, so how else can we test for dry eye? A lot of these are not done. They're more done in research, but I brought them up in case you guys do it or are interested in doing it. So the phenol red thread test, which probably none of us have done since college, since optometry school. Schirmer test, Inflammadry, and we have the show test as well. The show test is a little blood test you can do to help diagnose Sjogren's syndrome. Sjogren's syndrome on average takes about 10 years to diagnose. So if you can help in that, what I ask all my dry eye patients is if they have dry mouth as well, and that will really be a game changer because then I can send them to their primary care, write on a prescription pad, hey, you might want to get tested for Sjogren's syndrome, and then they have like things that they can do to help identify those underlying causes of inflammation. Questionnaires, not all, but just have one that you like. But there's various ones. These are just 3 of the common ones that you can do. But I love doing this because it really helps me understand how my patients are feeling before we get started. So we used to go from eyelid health to which is just basically eyelid cleansing, and now we have like a more comprehensive approach that includes eyelid cleansing, screening, risk assessment, patient education, coaching, which so it's gone so far, like we've advanced so much in dry eye. over the last few years, and it's really amazing to see. And we've learned a lot from our dentist friends, right? I think they've really guided us in a lot of the things that we're doing. I find it's, a lot of patients are leaving with a toothbrush at least, or an electric toothbrush they can buy. They're leaving with different products, different cleansers, different floss, and they have a whole program, right? And I think, everyone's been going to the dentist every 6 months since they were like 5. And I think that eye care needs to be the same. And it's just very similar now that we have mybography. We can show them the loss, we can show them pictures, we can show them what will happen if they don't do anything. And my favorite patients to educate are actually the dentist, because I'm like, hey, look what we got. It's very similar. So why is hygiene so important? Why is eyelid hygiene so important? Because we know that if, ultimately, bacteria on the surface of the eyes can lead to infections. For example, after, there's about 60% of patients who get cataract surgery who have staph, okay? And so if that's not treated, it can lead to our biggest fear of all time, which is endophthalmitis. But, meibomian gland dropout is another thing if there's poor eyelid hygiene. And again, once we lose those meibomian glands, they're gone, right? We can't regenerate them. So we really want to maintain good eyelid hygiene. So education is really important. This is like the basic thing that patients can do. So nutraceuticals, eyelid cleansing, hot compress, artificial tears. So if I have patients, obviously I talk to them about treatments that we do in the office, but if they really want to start at home, this is like the basic 101 at home treatment. Does anyone recommend this stuff to their patients? Yeah. So this is all stuff that's like the basic mainstay of like, let's start with this hygiene protocol. Hydration. So we talked about hydration earlier because Arizona is really dry, but anywhere, hydration, nutrition, environmental control. So are patients sleeping with a fan over their bed? Do they work in AC all day, like in a hospital setting? Are they working nights? Like you really have to understand your patients and really, I think, personalize, customize a treatment plan for them. So again, we talk about Demodex and the mite party on the eyelids. And now we do have a treatment for that, and it's so good and it works so well. And now we have data that this actually helps with MGD as well. So it's been really awesome. So this is what we used to recommend for our patients, and now we know it just doesn't work. So once I had a staff member say to a patient on the phone, like, "Oh, just use baby shampoo." Yeah, that was not good. So make sure your staff are on board with what you're doing as well, and not recommending baby shampoo to their patients. We have some great products instead. So we have hypochlorous acid, we have tea tree oil products, we have Manuka honey. Manuka honey is like a new friend in town, but so good. Just helps with inflammation. So something that I've been recommending a lot to my patients. And then, of course, we just talked about this for 30 minutes, but we do have some amazing treatments we can do in the office: IPL, RF, heat and expression with like thermal pulsation, or tear care. So different treatments to heat the meibum and express it, and treatments to help reduce inflammation like IPL. And then we have this awesome product that patients can use at home. It's like a toothbrush, but for their eyelids. That's how I tell my patients about it. But basically, it's like a microblepharoexfoliation that's safe and effective that they can do at home. So I do have some patients doing this twice a day. They love it, and it works really, really well. So they can do it with their eye closed or open, whatever they feel comfortable with. Eyelid massage. So, one of the things that makes the treatments in the office so much more superior is not just the controlled heat. So that's one big aspect. Think about the compress. You put it in the microwave for 20 seconds, and then you put it on the eye, and after 2 minutes, it loses most of its heat, right? So unless you have an electric compress, it's really not maintaining that heat. The other thing is we're not doing expression, right? And the third thing is that the compresses, they really don't direct heat to the eyelids, only they heat up the entire eye, which can actually temporarily increase inflammation. So what we're trying to do is melt the meibum. We're not trying to heat the eye. So it's obviously the treatments in the office we can do are a lot better, but if a patient is doing a treatment at home, they can't do gland expression, right? But they can massage, okay? And that will help kind of move that meibum. And so it's been shown that massaging actually helps. So from the in to the out, just like that. So if they are using compresses at home, we're applying heat to the entire eye. It's been shown that you have to use a microwavable compress every 2 minutes to get the same amount of heat. So you would have to like have another compress in the microwave while you're doing one to get the same kind of controlled heat. So it's just really not as effective, but it's much better than nothing. Unless again, there's like a big inflammatory aqueous portion to this dry eye, which we'll get to. But if it's mostly, lid disease related or meibomian gland related, then the compress is better than nothing. Again, there's so many products online, so make sure you're directing your patients to ones that you know and trust, and to websites where you know it's going to be not expired, not counterfeit products. I like to have a display in my office. This allows me to show the products and for patients to leave with the correct product when they go home. So this is what a potential display could look like, and it really gives the appearance that your practice is dry eye oriented, and so it really gives that patient the perception when they come in as well. And some of our Rockstar colleagues educating their patients about meibomian gland. So I love this this scale that you can show your patients about, this is regular meibomian glands, this is some mild to moderate loss, and then severe loss, and show them that it's progressive and here's where they are. And so it really helps them understand meibomian gland dysfunction. So we talked about perfluorohexyloctane, so I won't get too much into it, but it's first in its class, helps with evaporative dry eye. So if you do have the evaporative dry eye patient, this really helps prevent evaporation of the tears, as we saw in our talk earlier. And one of the things I love is to have this follow-up chart for my meibomian gland dysfunction patients, so my dry eye patients. If I do a treatment, they're going on a list. If they just go home with products, they're still going on a list. I want to follow them up. If you're starting, let's say, lotilaner for a patient, you want to make sure you follow up with them. If you're starting perfluorohexyloctane for a patient, you want to make sure that you see them, because you want to make sure that the treatment is working. Should you add something? Should you change something? And so depending on how severe it is, this is just what I do, but you guys can find something that works for you. So if patient is mild, I like to see them like every 8 to 12 months. If they're more moderate, every 4 to 6 months. And then severe, I'll see them every month or more, like sometimes every 2 weeks, especially if I'm doing a treatment. Obviously, I do multiple sessions, and so I'll see them more often. So let's say you have a patient with severe ocular surface disease. You think that there's an aqueous component and it's not just evaporative, right? So we talked about 85%. What about those other 15%? Some of them, their glands are perfect. They just don't produce enough tears. So that's a little bit of a different situation. You could do all the IPL and RF and everything that you want, but their meibomian glands are good. So this is a situation that's less common, but still happens, okay? And again, sometimes it's mixed. Sometimes you have both, right? So it's really important to understand, what's going on, because the underlying cause is different, so the treatment is going to be different. So if I have a patient with severe ocular surface disease, I love to use an amniotic membrane. There's different kinds. There's dehydrated membranes. There's cryopreserved membranes. They have amazing clinical benefits. They help the cornea heal like no other, and it's a really great treatment. Growth factors, cytokines, anti-inflammatory proteins. It's really amazing, and amniotic membranes are used in other parts of the body as well, like for severe wounds and healing. It's really, really revolutionary. So scleral lenses, which I talked about again earlier. So this is basically a fluid reservoir that we can put on the eye, and it helps restore the ocular surface health and also protects the eye from outer influences like the eyelids, any friction from the eyelid. I showed you guys earlier, the eyelid friction, the lid wiper, but any environmental threats as well, and it does help heal the ocular surface. So it's a really amazing treatment. So again, we can see just the benefits of using a scleral lens on the ocular surface. So improve anterior ocular health, reduce symptoms in patients. Patients do feel a lot better when they use a scleral lens. And you can make them really large too. You can go, I have like a patient wearing a 20 mm lens. Sometimes you can go bigger than that. So let's say they have a lot of conjunctival staining too. You can really go quite large with these lenses. What's important here, so there's always going to be a pre-lens tear film on top of the lens. So let's say they have a mixed component. So they're aqueous and they're evaporative. You have to make sure that the oil component of the tear film is good, is uniform. So you may have to do a scleral lens and eyelid treatments as well, because you want to make sure that just because you're hydrating the eye with a scleral lens doesn't mean you should ignore the eyelid. So you really sometimes have to do both. Again, it depends on the case. So we talked about inflammation, we talked about the dry eye, the vicious cycle, about interrupting inflammation. Again, if you see that a patient has rosacea, telangiectasia, you know you can address that inflammation with IPL. But if they do have inflammation, let's say they have, it's aqueous, right? It's an aqueous component, then we do have immunomodulatory agents that can help reduce inflammation a little bit more upstream. So we talked about lifitegrast, we talked about cyclosporin. So these drops are amazing for reducing inflammation a little bit more upstream. And then we have a neurostimulatory tear inducer as well. So this is a nasal spray which stimulates the lacrimal gland to produce more tears and better quality tears as well. So you don't stick it all the way up the nose, okay? So it just goes on the outer portion of the nostril. That's where the nerves are that go to the lacrimal gland and help the lacrimal gland produce more tears. So this is a great treatment, especially for those contact lens wearers, because they don't have to remove the lens in order to use the spray. Obviously, it goes in the nose. And then you have your ASG and your PRGF. So this is basically made with the patient's blood. It's then centrifuged. So the difference between PRGF and ASG is what's in it. So ASG is just serum and PRGF has platelet-rich growth factors. So I've actually switched most of my patients over to platelet-rich growth factors. It actually works better, especially for those Sjogren patients. So really, you know, find out what type of dry eye you have, but the PRGF has been a little bit better for a lot of my patients. So you'll have to work with a specialized pharmacist or phlebotomist on this type of drop, but it really, really is helpful. And then different things in the pipeline that we can all look forward to. So we've got Trypamate, which I think should be approved later this year. So targets transient receptor potential melastatin 8 or trypamate, and it's a cold sensitive ion channel in the cornea. Reproxalap, also a small molecule modulator reactive aldehyde species aiming to reduce ocular inflammation. And then lacridin-based therapies, which utilizes the tear protein lacridin to promote ocular surface healing and nerve regeneration. So things to look forward to. And basically, you always want to determine the underlying cause. The treatment is not going to be the same for everyone. And I think that's really what I want to leave you guys with. A patient, most of the time, they're probably going to have evaporative dry eye, but they may not. And again, you can't do the same treatments for people who have aqueous deficient and evaporative. I think you really have to figure out what's going on. And if you do that, then you can customize the treatment for the patient rather than just giving them to every patient the same treatment, and it may work for some and not for others. If you figure out what kind of dry eye they have, then you can fix their problem and they will be eternally grateful and it will change their lives. So excited for what the future holds for dry eye. It's developed so much over the last 10 years. And thank you so much for your attention.